Hey everybody, welcome to the support here. As always, with my two partners in crime, Matt Kachansky, the retired special agent in charge from the OIG, the retired Northeast UPIC director, and currently our payment integrity director here for our in-house SIU team. And Wade McFall. If you're from the Northeast, it's McFall, but we'll go with McFall for the Midwesterners. Retired assistant special agent in charge from the OIG and a manager on our SIU team. So today we want to talk about a press release that came out. I said past couple of podcasts and some of the press releases that are out there. And the one for today that we want to spend a little bit of time talking about comes out of the Eastern District of Missouri, or I guess it's Missouri, depending upon who you're talking to. We don't see a ton of press releases that come out of some of these smaller districts for whatever reason. Obviously, there's a small number of agents, small number of cases that come out. But this one's a pretty interesting one. So obviously $2.8 million, so it's not a small amount of money. Involves a doctor, a few doctors, a chiropractor. It involves at least two doctors, a chiropractor, a laboratory, and some pharmacies. There have been well over a dozen people. It certainly looks from the press release that there are some people that are cooperating in the investigation, because you got people that have pleaded guilty back, several years ago, and it looks like there's been over a dozen people that have been wrapped up in this. But the long and short is two doctors and a chiropractor were involved with writing medically unnecessary prescriptions for Schedule II narcotics, and they were doing urine drug tests. The urine drug tests were going to a lab. The lab was paying kickbacks back to the doctors in return for those samples, and the patients were all being steered to a pharmacy or pharmacies in the area to get the prescriptions filled. And there's a couple of notable things. One in the that the patients were selling or diverting the drugs, and we'll get to that in a minute with Matt about how does a patient record tell you that they're selling or diverting, because who's going to tell their doctor? And the patient is admitting that they're selling or diverting their drugs each month, but I'll continue to write these prescriptions. But the doctor's writing these prescriptions, and it was the evidence, according to the press release, reflects that the patients did not have any medical conditions that required it. It looks like the doctors were pre-signing prescriptions, not examining or treating the patients. It was really a pill mill in the truest sense. And then, just from a historical perspective, I remember working on a case just before I retired where it was exactly that. The provider was away on vacation. He pre-signed prescriptions, and when the patients would come in and need their refills, staff would just hand them the prescription because it was pre-printed. For the most part, the handwriting of prescriptions is quickly going away, and different states have different rules to not allow prescriptions. It has to be e-prescribed to the pharmacy directly to help stop some of on the prescriptions. For example, manipulation of dose, manipulation of quantity, right? If it's in black pen, you take out a black pen and you change the 1 to a 4 for refills, for example, or you change the 10 to 100 for milligrams or something like that. But wait, this brings up an interesting point, which is from a data perspective, an SIU investigative perspective, one of the things that's always interesting is we spend a lot of time talking about pontificating, analyzing, and reviewing CPT and HCPCS codes, and understanding the interplay of CPT and HCPCS codes to LCDs, NCDs, and billing. And I think oftentimes where we get a little lost in the sauce is we don't always focus on diagnoses, right? ICD-10, ICD-11 is coming out. It's actually out, but CMS hasn't adopted it yet. I think that's coming down soon. But ICD, International Classification of Diseases. When we started, it was probably
pre-ICD.
Pre-ICD. It was you wrote out cut on arm, and that was it. But now we're on ICD-10, and diagnoses are classifications, and you have to understand that in a lot of instances, right, when we're talking about E&Ms, for example, almost any diagnosis is going to fit into an E&M. But as you start to get more granular on things, the diagnosis has to kind of fit whatever that condition or treatment is. And where we a lot of times focus on CPT and HCPCS codes for your outliers, we oftentimes don't focus on diagnoses. And the thing that's interesting about that is that when the patient has a diagnosis, one would expect it to kind of carry on over time. For example, something like this: if someone has a diagnosis of lower back pain and they're getting a medication, an opioid to treat that lower back pain, once it suspects some other things in the data, right? And this is another area of investigative opportunity, I think, where we get so hyper focused on policies with CPT and HCPCS that we miss sometimes the fact that the diagnosis code can give you a really good indicator of other areas of FWA in that historical billing history.
Right. And in this case, too, I mean, the diagnosis, I agree, is often overlooked. And in this case, it could have been one of two things. It could have been more of a flag, or it could have been irrelevant, because we know that from the press release that they said that there was no medical necessity or no legitimate purpose. So the visits were for the kickback money and not for, medical care. So in that case, along with the fact that the prescriptions were signed ahead of time, signed blank forms without names. They didn't examine the patients prior to they're not actually diagnosing a member or a patient with a condition or disease. They're putting it on the form so that they can prescribe the medications. So in that sense, it may or may not be a red flag that you're able to follow up on. They also build for, annual wellness visits, which is in itself not a problem, but a lot of times they'll do that where it's just another reason it's kind of more of an extended annual visit. They talk about it as being a wellness visit where they'll kick back related. So it's the same about often those types of flags. It's the same circus, different clown scenario. And in this case, it looked like they had some attempts to kind of hide the kickbacks, because it had mentioned that one of the doctors had paid for one of the other doctors' employees' wages, which can be a safe harbor. But again, as we spoke about last week or 2 weeks ago, that the specifics make all the difference in the world, because that can be a legitimate safe harbor where one doctor can essentially pay the other through the form of a bona fide employee. But again, it's the specifics. If it's not covered by, it's not reviewed by a healthcare attorney, and you kind of you think what the safe harbor is, you're going to get jammed up, because it's very specific and has to be written a certain way. So that was one area that it looked like they were attempting to kind of either cover up or negate the pain and the kickback, but it obviously didn't work, because that was part of their in the press release.
Right. And the thing about that is that sometimes what you see in those kind of instances is the amount of cash that needs to be generated to pay the kickbacks is just an amount of cash that the kickback payer can't come up with. Sometimes you get into a situation where it's too much money. You can't get that much cash one way or another. So you do it through these other means, right? If the lab or someone is paying the salary of an employee, and that employee's salary is $40,000 plus benefits, right? Let's say it's $50,000 if you throw in healthcare or whatever else it is. That's $50,000 that the kickback receiver is able to keep in their pocket. So there's no actual cash exchange. And if the amount of the kickbacks exceed $50,000, it's a lot easier to drum up 5, 10, 15,000 than it is 70 or $80,000, right? Particularly since, where are you coming up with $80,000 in cash? And Wade, the other piece of this that always kind of I find interesting is if the person has a diagnosis of lower back pain for which they're going to get a prescription for oxycodone or some Schedule II drug or something like that, the other piece of it is when were they first diagnosed with that lower back pain? And is there a history in their billings of, did they go to a pain management doctor first? Did they go to, did they get injections? Did they try cortisone shots? Did they try physical therapy? What other modalities were out there? Is there an MRI? Are there x-rays? Are there other things for the patient population that are getting oxycodone? And this is where, right, this is where your pharmacy data and your medical data have to be looked at together. You can't look at them in a vacuum when you're looking at these kinds of cases. And how many of the patients, and this is where diagnoses codes come in, how many of the patient population that these doctors are seeing are having lower back pain as the diagnosis? Now, the challenge is if the provider is a pain management, L5S1 lower back pain is the most common back injury. We all probably have something wrong with our L5S1, right? So it's just a common thing. But I think, oftentimes these diagnosis codes become overlooked because we get so hyper focused on those other pieces. But the thing you brought out, and you brought this up before, is this important aspect of does any sort of agreement where you're bringing a safe harbor into play, is it smoke and mirrors versus legitimate? And one of the big things is the employee whose wages are being paid for by the ancillary provider have to exclusively do the work for that ancillary provider, meaning the person that's being paid, right? They can't be answering the phones, doing filing, putting patients in the room, playing medical assistant, and doing this other job. It's got to be either segmented, or you're only paying a portion of that. So that becomes, when I read this, the first thing I'm hyper focused on CPT and kickbacks codes, that we oftentimes miss the fact that the fraud, it's a diagnosis code. I'll give you as a collateral example, and then Matt, I want to turn to you, is there's a procedure G0166, external counterpulsation or enhanced external counterpulsation, ECP or EECP, and it's for patients who have unstable angina who are not candidates for surgery, and they sit on a table with these boots, and there's a compression that goes on that is done between your systolic and diastolic blood pressure. And the normal course of action is 1 treatment a day, 5 days a week, or up to 2 treatments a day, 35 treatments. But you have to have a diagnosis of unstable angina, and you have to have a referral from a cardiologist that says you are not a candidate for this. And I've seen a whole bunch of these cases, and I think G0166 is starting to pop up again. But I've seen a whole bunch of these cases where patients didn't have the diagnosis of unstable. Should have had a visit from a cardiologist with maybe unspecified heart, whatever the normality is, and then a test to determine, right? So there should be a history that ultimately leads to that diagnosis. You shouldn't all of a sudden get that diagnosis on the first day of service, because the cardiologist has to have already indicated that you weren't a candidate. So, in those cases that I've looked at here and in my past life, you can look at the diagnosis history and see, hey, how's it that all these patients didn't get a diagnosis of unstable non-surgical angina until the very first day of them having the service? It just seems not plausible. So it's something to look at. So Matt, I want to, turning back to the press release, the interesting thing, and I mentioned this when we started, was the fact that the patient's records indicated or were documented to reflect that the patients getting these prescriptions were diverting or selling the drugs. And the last time I've looked, I don't know of any nefarious doctor who would write, patient is getting prescription oxycodone, sell it. So what I mean, I laughed when I read it, because
I don't think they were telling their doctors they were taking the drugs and selling them. No. What you look at the scheme in toto, these doctors and the chiropractor, they're billing for their services to these patients, whether they did them or not, the wellness visits and all that. I think that's irrelevant. What they were doing is writing scripts for oxycodone or other Schedule II drugs unnecessarily, probably for patients they've never met. They were also, as the kickback part of this, ordering the urine drug tests for those patients. And what is the purpose of those drug tests? Is to make sure that the patient is taking the prescribed drugs in the right amounts, as well as not taking anything else. And they're supposed to keep track of that, because if the results come back the reference to the in the press release is those test results were showing that the patients weren't taking the prescribed drugs, so it was known that they were doing something else with them, obviously, or diverting them in some way, maybe selling them back to the pharmacy. We don't know, but they certainly weren't taking them. And this goes back to, what we talked about last week, where the medical necessity of the services being provided, especially for a test like a urine drug test, is it's supposed to impact the care of the patient. Well, here the tests are showing that the prescriptions being given out by these doctors weren't being used, but it didn't change the behavior of these doctors. They continued to write the scripts because they were getting the kick and parcel of the scheme, that all of it is sham medicine, probably something that's worthy of a referral to the state licensing board for any and all of them, and shows that the kickbacks were pure, all of their services, all of their prescriptions were purely for money.
Yep.
And it's just indicative of this isn't medicine. This is drug dealing.
That's a good point, Matt. This is really like what I liked about this press release. I mean, liked is a relative term, but it had a little bit of everything it had a little bit of something for everyone, right? You have kickbacks, you've got urine drug tests that are bogus, you've got prescriptions, drug diversion going out, right? You got healthcare fraud because they're going to be likely they're billing. Wade, do you really think those wellness visits were taking place? I mean, maybe, but it's smoke and mirrors, right? You had a little bit of everything. You have misrepresentation because the patients are probably not getting an E&M or what they're really there for. My guess, kind of throw the spaghetti on the wall. And in this case, everything seemed to stick. I mean, when I read this press release, it was enjoyable to read because there were so many different things going on. The one thing I think that always resonates with substance abuse related cases and the urine drug testing and the quantitative and the qualitative is if you're a pain management doctor or a doctor that writes a lot of prescriptions for narcotics, obviously, your general internal medicine, your general practitioner. I mean, I could tell you, I have some friends that work at urgent care. I have a good friend who's a PA. The industry won't even write a prescription for a cough suppressant that contains codeine anymore, right? There are some cough suppressants, promethazine, also known as lean or Sizup, right? You'll see people drinking that when it has codeine in it. If you've ever taken it, it tastes terrible. So what people do is they do it. You'd make it very cold. So for those of you that go into your local neighborhood corner store, if you find in the freezer section of your local bodega, for those of you who don't know what a bodega is, that's a New York City term for a corner store. If you go to your local corner bodega and you find in the freezer section styrofoam cups by the case that are frozen, it's because people in the neighborhood are taking promethazine with codeine because that's one of the giveaways for it. But it's a very effective cough suppressant. You go to urgent care, you'll get promethazine minus the codeine. A lot of places are very reluctant. And so your general practitioner is probably not doing medication management for you. It's typically going to be a pain management doctor, which then kind of begs the question, if that's the case and people are on these long-term low dose or whatever prescriptions of a narcotic, shouldn't at least there be baseline drug testing through your process done? Not uncommon. You would likely see that when a patient comes in for medication management in the billings, you should typically see an E&M, right? A low-level E&M for that medication management visit with the pain management doctor. You should see some urine drug testing. And then if the drug test comes up positive, the potential of that urine sample going to a lab for further tests, in part because it's not so much to see if the person is using other drugs, but sometimes it's also to ensure that the person is using the drug at the therapeutic ranges, right? Meaning in this case, Matt, if they're getting the prescription and their urine drug test is negative, they're not taking the drug, i.e. they're doing something with it if they're constantly getting that prescription, which is where you're coming to that conclusion that they're diverting it, selling it, or doing something else. What I liked about this, again, this one has, so you got your urine drug test, you got your doctor visits. Heaven knows what the chiropractor was doing, because in the Medicare space, chiropractors only have, I think, 2 codes that they can bill for that have to do with adjustments, subluxations of the spinal column. And so, did we have a doc in the box scenario here that we don't necessarily know about, where the chiro is the owner of the practice and they've got MDs working for them? And then you've got, obviously, the prescriptions going to friendly pharmacies, because the pharmacies clearly know what's going on when the patients are coming in to get these drugs. So this was an interesting one just because there was so much out there. But, I think you got to look at these in total and see, particularly, and Matt, you brought this up, clearly there are people that are trying to help their cause, right, because of the time lags in plea and things of that.
Getting a plea agreement in May of 2024, still haven't been sentenced. That means they're cooperating.
Right.
They're holding the sentence to see what the breadth of their cooperation would be. But
right.
What was you missed the most important part of the press release. They worked a night signing these, for an SIU. Spikes in the billing for those oxycodone coming from certain sources. You got to look for those spikes.
Right. So Wade, I want to give you the last piece of this, which is when you have these, right? So the press release talked about, basically signature parties, right? They're working for hours. They're working for hours at the close of the day, right? Employee interviews, former employee interviews. This is where doing your homework to identify who your potential pool of interviewees is going to be important. Because at the end of the day, right, you might interview someone who might not have any nefarious knowledge of what's going on, but they're going to say, I went home, and when I came back in the morning at 8 o'clock, there were 100 prescriptions that were already signed on the table for me. And I don't remember that, right? So the person might not know anything, but this is an example. And, last word is, you got to do your homework, right? Figure out who these people are.
Right. And in order to get them to pain already. So you have to find some way to, I don't want to just say jam them up, but you have to find out what their involvement may be, and you have to make them realize that whether you like it or not, you're probably involved with this. And it's, you have to get them to have a reason to start telling the truth, because in most cases, they're not completely oblivious to what's going on, and they're gonna answer your questions like they are until you confront them with something that's gonna maybe jump a little bit, and then they realize that they have to start talking. But short of that, they're not gonna come out and say, "Oh yeah, they're writing scripts," and they're not seeing the patients, or they might also see if they're involved with the medical charts and stuff. That another kind of weird sequence is that if they're at this pain med doctor and they their billing history, and this might be difficult to do in an SIU, but you look at their billing history over the years, and they've had their primary care physician as being the same person for years, and then right before they start going to the pain med doctor, they get a referral from another doctor who's not their normal doctor, and it's the first time they've seen them, and now this whole sequence of prescriptions and visits happens when they've had the same general practitioner for years. But getting back to the question, they're really not going to be open and tell you all the truthful answers. So you have to do your homework, like you say, and find out what those circumstances it's time to not cover for your employer and start telling the truth.
Right. Yeah, that's where the good point you make is if you've been going to the same internal doctor for years and years, maybe it's worth taking a look at the records from that. And because if you have lower back pain that's led you to go to a pain management doctor, one would suspect that you would have at least had a conversation with your primary care physician about that. Maybe there is a referral, maybe there isn't, but I would suspect that, all of a sudden the person didn't wake up one day and say, boy, my back hurts. Let me go to this pain management doctor and get Oxy. You're going to say, wake up one day, go, man, my back. Start with a orthopedist. Maybe you go to your general practitioner and say, oh, what can I do? And your general practitioner says, oh, let me send you to, let's try physical therapy, right? So so that billing history and those diagnosis codes are always going to be part of it. So this was a great case. Good work by the offices that did it. It was DEA, OIG, and U.S. Attorney's Office. It was an interesting case. Obviously, a lot of people got scooped up. Probably a few more out there. We'll see what happens. But I love. Yeah. FWA, right? I mean, this had a little bit of everything, which makes it an interesting case to work on. So
there were some links to the other press releases, and I think so far there's defendants pled guilty based on this one scheme, so it's far-reaching.
Right? Yeah, it is. It's and there's probably more. There's probably going to be more out there because these are mills, and that's where they make their money. So interesting case as always. Good perspective. Keep an eye on your diagnosis codes. It's not always about CPT and HCPCS codes. I think sometimes diagnosis codes become the redheaded stepchild, right? Of the no offense to redheaded stepchildren, clearly. So yeah, good stuff. We'll keep it up. As always, thanks for tuning in, participating, and sending us your comments, questions, and concerns on these different topics on LinkedIn and through our webpage and other places. Again, you can sign up, get your information right to your inbox on Fridays. Get us on LinkedIn. Get us on our email at hello@advisehealth.com. And again, as always, we appreciate everybody, and we'll see you on the next OIG Roundtable. Have a good one, everybody.